All right, I think I've got everything set up here. Good morning, everyone. Welcome to PT on Ice Daily Show. My name is Jessica Davis, and I am lead faculty for the Performing Arts Division of ICE. And I'm coming to you today from Pittsburgh, Pennsylvania on a cold winter day. Well, I guess it's technically fall. Feels like winter, though. Okay, so we're going to talk about management of TMD. And I picked this topic because it's something that I don't believe we've talked much about in ICE, but I thought it would be something neat to cover. And there was also a really neat article that came out in JOSPT recently. Well, it's 2014, but it came out in 2014, and the title is Proposed Classification of Patients with TMD for Patients. And this is a neat article because I thought it kind of gave a good guideline and a nice summary of how we treat this patients with TMD. So I'm just going to go over that. So patients who present with to us with TMD can have a variety of symptoms, and it's important to know, number one, if we need to refer, if they need to be treated conservatively, and kind of what direction we should take with these patients as always. So the treatment for these is multidisciplinary, so meaning that we as therapists are the clinicians that should be treating these patients, as well as dental practitioners, and even in the classification they talk about referring patients to potential psychologists or psychiatrists, and we're going to go into that. So the incidence of patients with TMD is actually higher than I thought. It's 35% of the general population. However, only 5 to 10% of these patients actually seek treatment. So that I found interesting, and a lot of it is if it's painful and limiting, obviously, in their ability to open their mouth or chew or sleep as well, they will often seek treatment. So the different classifications I'm going to go over because I thought this was kind of neat because it helped kind of guide our treatment. So the first classification is just masticatory muscle disorders. So those patients are primarily the muscles around the TMJ are involved, or even into the cervical spine, and these patients will benefit from management of the soft tissue dysfunction that we find. So the muscles that are specific to this region that we need to pay particular attention to are the lateral pterygoid, the medial pterygoid, the masseter, and the temporalis. So the lateral pterygoid is difficult to palpate. However, one that is beneficial is the medial pterygoid, and I wanted to go over that today, and it's a little bit, I can't really demonstrate it, but I'm going to kind of describe it. So patients with medial pterygoid symptoms, they're going to have pain if you palpate inside the mouth in the back corner. So just to the posterior aspect of the molars, so on the bottom aspect, so kind of that back corner in the jaw. If they're tender there, that medial pterygoid attaches to the disc, and it can create disc-like symptoms just from the fact that it's taut and overactive. So this is a muscle that will benefit from soft tissue mobilization to that region. And so that's an area to pay attention to in addition to the masseter. So what's nice in this article is it goes over, and I'll put the post up for that, but it goes over specific regions in the face, jaw, neck that we can find with when we palpate these muscles and how they will create symptoms. So how do these patients develop these issues? It's basically from overuse. So if they have prolonged guarding, then they can get that soft tissue restriction. And so also these patients can have central mediated myalgia that can create these type of muscle type issues, or overuse and strain. So it's important in the subjective history with these patients to have an idea of any kind of parent functional activities such as grinding. So a lot of patients may grind their teeth, especially at night. We're going to go over that. But grinding their teeth, nail biting is a common one, chewing gum, and just in general, those kind of overuse type habits that you may see and you may have to ask in your subjective history. So if you get an indication that this is going on, you want to address that in treatment as well. So how do we examine that? So we're going to palpate the region around all of those muscles, and it's important, and I'm going to go into exam, but it's important that you do not ignore the cervical spine. So Jeff Moore did a great podcast yesterday, hopefully all of you saw it, on the cervical flexion rotation test. And this is one that they actually cite in this article because it's important with these patients because these patients may have headaches. And it may be derivative from the TMJ, but they also may have headaches because of a cervicogenic headache. So one special test, and again, I would watch it. I really love, I'm actually going to show my students this morning because it's a really neat way of doing that in a different way where you're looking at the thoracic spine. So watch that video. But if these patients have a positive cervical flexion test, in addition to local hypermobility in the upper cervical spine, and they're complaining of symptoms in their TMJ, you need to treat that. So, and they can have, as we know, multitude of disorders, but you've got to treat that. Okay, so again, you want to address the protective muscle guard, and you want to address any symptoms that they're having related to soft tissue. So these clients are going to benefit from manual therapy as well as patient education. A lot of these patients, as we know, have poor postural, so maintenance, so addressing that and whatever they're doing during the day. So the next category, which I really like, which they added, this is a new category, and it was central sensitization. So we talk a lot at ICE about pain sciences, and so this is the centrally mediated myalgia. So patients can have central sensitization, and how do we know these patients? Again, these patients present with a variety of symptoms, and it may be extra sensitive to light touch, palpation. They're going to get referred pain maybe to the TMJ, but it may be elsewhere. So it's important to differentiate. But again, you can see in these patients it mentions that they may have an inhibition of local blood flow to the region, so you may see that. And they're obviously going to have increased nociceptor activity. So these patients, if you detect that they have central mediated myalgia or central sensitization, we're going to treat these patients differently, right? So we're going to address that early, and we're going to take a whole different path with these patients and address them properly. So so this is what I found interesting about this category that I did not know personally, but I knew patients with TMJ can present with headaches. So to go over that, so a great way to palpate the mechanics of the TMJ is actually to palpate in the ear. So you guys can play around with that, but if you palpate in the ear and you open and close your mouth, you can really feel the articulation of the TMJ with opening and closing. And if they have local tenderness, that's an indication to help you assess if there's actual joint pain. But patients with central mediated myalgia can have an earache. They can also have facial and headache pain. But the other thing that these patients can present with, which I found unique, is vertigo. So imagine if a patient presents with vertigo and it ends up being from TMJ, central mediated myalgia. So interesting food for thought. So if you have a patient with vertigo, another that should be on your differential diagnosis list potentially. So the third category is joint dysfunction. So joint dysfunction includes a multitude of symptoms, obviously. So it could be the actual joint, it could be the capsule around the joint, the ligaments, and it could also be the disc, it could be the synovium and the synovial membrane, because this is a synovial joint, so don't forget it has a disc, it's a true synovial joint. So it's important to differentiate any structure in that region and classify that appropriately. So what I like about, so I remember as a student getting confused with the disc, the TMJ disc, and all these diagrams and just thinking about it too much. So I like that it kind of creates sort of an easier way to think about it. So there's two classifications of disc type symptoms that these patients can have. They can have a disc disorder with reduction or a disc disorder without reduction. So I'm going to go over how you can differentiate these easily. So the mechanism of injury of these could be microtrauma, and microtrauma meaning from repetitive overuse. So repetitive overuse, as I mentioned before, from those parafunctional activities such as bruxing, grinding, nail biting, etc. So it's important if you find that to address that in your patient education. But they can also have these patients can have macrotrauma. So that being a direct blunt hit to the TMJ or face, or it could be from a prolonged dental procedure where they had to have their mouth open for an extensive period of time. So it's important to, or even from intubation. So if they had a recent surgery and they were intubated and they're complaining of symptoms, so you need to pay attention. They may be presenting to you with an underlying TMJ dysfunction. So here's the key to recognize the difference between the two type of disc-related disorders in this classification. So if the patient has a click with opening and a reciprocal click with closing, then that is a patient that is having the disc reduced. So that follows in the disc disorder with reduction. So some of these patients require treatment and some do not. So those patients who have a click that is non-painful, then the recommendation is actually they don't require treatment. treatment. It's just something that they may have. It's just a click. It may not be an issue. If they have pain, however, then it requires treatment, and the evidence is supportive of conservative management with these patients. So what do we address? We address whatever impairments we find. So whether we need to do local joint mobilization, whether we need to do soft tissue mobilization, and as always, you follow that up with the proper exercise. You're treating the cervical spine if they have that underlying issue there. So it's a multitude of variables. Whatever impairments you find, treat them. So the disc disorder without reduction, the key feature here is one click. It is click with opening, and they also will have an associated limitation in range of motion. These are the patients that cannot open fully. So if normal opening for the TMJ is 40 millimeters. So if they're not opening to that full 40 millimeters and there's a difference side to side, or you're just seeing a lack of opening, then put that higher up on your hypothesis list that they may have an underlying disc-related disorder. So what are our differential diagnoses with these patients? So it could be, again, it could be headaches. They could be primary headaches. They could also be secondary headaches. They could have cranial or peripheral neuralgias or other CNS disorders. So there's a multitude of variables that we need to assess when we're doing our history, right? So I liked this too. So key questions that are highly sensitive to ruling in TMJ disorder. So here's the questions, and I'm just going to read them verbatim so that you know. One question, question number one, have you ever had pain or stiffness in the face, jaw, temple, front of the ear, or in the ear in the past month? Good question. Are your symptoms altered by chewing, talking, kissing, yawning, or moving your jaw? Third question, have you ever had your jaw lock or catch so that it would not open all the way up? If so, was the limitation in jaw opening? And was it severe enough to interfere with your ability to eat? And the fourth question is, have you ever noticed clicking, popping, or other sounds in your joint? So you can tell which questions are sort of related to the disc-related disorders or other disorders. So how do we examine them? Number one, we're going to do a significantly detailed subjective history, as we always talk about. That's the most important thing. Followed by, you're going to see if they have any kind of parafunctional activity, such as the chewing gum, pencils, etc. You're going to look also at their teeth. So some of these patients are not aware that they may be grinding their teeth at night. They're not aware. Obviously, we're sleeping, so we don't know. So if you have them open their mouth and you see that there's evidence of wearing on the molars or the back teeth, or just in general, you may be suspicious that they may have some grinding at night. Another feature is if the patient wakes up in the morning and you ask them specifically, do you have pain upon waking? So the patients who have pain and limitations in range of motion potentially upon waking, those are the patients where you need to think potentially they're grinding at night. And this article does a good job where it says these are the clients that may require a referral to a dental practitioner because they may need a specific split to wear at night that will help prevent the grinding. And there's some talk about, well, can they just use, a local, I think of my kids with their hockey mouth guards or something, and they could just use that at night. And the answer is no. There's evidence that if they use that type of thing, they actually could make the grinding worse. So it's important that they have that specifically designed for them. So again, that's a key feature if they have pain upon waking. And do you see evidence of, gray wear and tear on their teeth? So how do we treat these patients? We treat the impairments we find. So it helps if you can classify them and then follow up that with particular treatments based on whatever impairments you find. You want to educate. Education in this patient population is huge, so trying to minimize those parafunctional activities. Also, if you detect that there may be high levels of anxiety or depression, which that may exist in these patients, you need to properly make the right referral. So a lot of these patients do have that, and so making that referral. And then dry needling, they mentioned, very successful, especially if you have the soft tissue related component. And then they may need that intraoral appliance, pain science education if they're following that central sensitization, and then maybe a consultation with a dentist or another practitioner, an oral surgeon, and then following it up, we always following manual therapy, we're going to do the proper exercises. So one of the exercises that you guys already probably learned in school is the Rockabato 6x6 program. So I'm not going to go into detail about that, but look it up if you aren't familiar with that. So hopefully that was a good review. I know it was quick, but I gotta go. I gotta give a lecture real quick here. So thank you for listening. Again, I teach the Performing Arts Division of ICE, and I have a course coming up. My next course is going to be in June in the summertime in Chicago. Thanks to Rally PT for hosting me. So if you want to come for a summer trip in Chicago, learn something about dancers, and hang out with me, please come out to that course. It's June 27th and 28th. Thank you for listening, and if you have any questions about TMJ, or TMD actually is called, don't hesitate to reach out, and looking forward to seeing all of you, hopefully at the ICE Sampler. And also follow, if you don't follow Hump Day Hustling, go to ptonice.com, scroll to the bottom, become a follower of that. We put something out really awesome every week, and it's just awesome. So anyway, thanks for listening, and have a wonderful Tuesday. All right, take care, everybody. See ya.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.